She really doesn't let me sleep many times because of her questions, persistent questions. She has served, before joining FP 2020, Chong-hee served as director of the Korea Foundation for International Health Care, and she developed mid and long-term strategies for bilateral official development assistance with the Korea International Cooperation Agency. As I mentioned earlier, she's a very hardworking colleague. I would like to welcome Chong-hee to share her experiences with us. Thank you.
Sharma. Good morning, Namaskar. My name is Chong-hee Hwang. I feel very excited and honored to join this invaluable event with many colleagues from many other organizations in the region. So the Family Planning 2020 was launched as an outcome of the London Summit on Family Planning back in 2012. And today, IBP 2020 serves as a central platform for progress in the family planning sector. IBP 2020 is country-led, globally backed movement to empower women and girls by investing in rights-based family planning. IBP 2020 works with government, civil society, multilateral organizations, and donors and private sector, and also research and development community to enable 120 million more women and girls to use contraceptive by 2020. And this goal is very critical milestone to ensuring sexual health and sexual and reproductive health and rights and services by 2030, as laid out in SDG 3 and 5. IBP 2020 can only succeed in delivering results by supporting and magnifying efforts of the global and country-level partners, playing the role of convener and facilitator, and focusing on catalytic actions directly linked to the achievement of the IBP 2020 goals. In order to have the most impact over the final years of the IBP 2020 partnership, IBP 2020 is prioritizing efforts on 4 cross-cutting areas, such as driving country-level support, promoting data use and performance management, and sharpening the focus on global advocacy, rights, and youth, and facilitating dissemination of knowledge and evidence. This slide shows the key elements of IBP 2020 and how it functions at the country and regional level. The IBP 2020 process begins when a country makes a commitment. The commitment is a specific statement of intent outlining country strategic direction and high-level priorities, and setting an IBP goal that the country strives to achieve by 2020. And a cornerstone of IBP 2020's country support approach is the focal point structure in each commitment-making country. A team of focal points consists of one each representative from the government, civil society, and core donor partners, and work with IBP 2020 Secretariat and many different partners and stakeholders to drive the progress on the country's IBP 2020's goals. And accurate data provides a solid foundation. So acknowledging that, the data consensus meetings are convened in countries with support of Track 20 to review the progress and identify some missed opportunities. Data findings and discussions shall be interlinked with high-impact practices as evidence-based intervention that can be used throughout the program to maximize the effectiveness. And the core-state implementation plan is a multi-year roadmap that the country strives for the family planning strategy. It covers all the major thematic areas such as enabling environment, financing, and supply chain and service delivery, including social and behavior change, and monitoring and evaluation. So the government collaborates with stakeholders, with EPI 2020 partners to develop and implement that plan. And every 18 months, the Focal Points attends the regional EPI 2020 Focal Point workshop with experts and partners and with EPI 2020 Secretariat. And as one of the main outcomes of the workshop, each country Focal Point team develops a country action plan. The workshop also works as a platform for cross-country learning exchange and knowledge sharing. We had a second Asia Regional Focal Point workshop last year in May, and the third one will be organized later this year. And country actions for acceleration plan is a short-term agenda of immediate next step to achieve the commitment and national family planning strategies and costed implementation plan. We encourage countries to make sure the action plan is first drafted through the country discussion with engaging broader stakeholders before coming to the workshop, and also have it validated by the same consulted group when they return to countries to finalize and publish it. So as mentioned earlier, the cornerstone of the EPI 2020 country engagement strategy is a country focal point structure. Recognizing the critical roles of the CSOs and formally integrate the civil society's voice into the EPI 2020 initiative, last year we began the process of expanding each country focal point team to include civil society focal point, starting from Asia region. Civil society focal points represent the family planning civil society organizations' voices in country and deepen and strengthen sustainable partnership at the country and regional level. Country action plan consists with the following key components. So the front cover shows the country snapshot with key core indicators and MCPR growth status on the S-curve. So this gives an overview where a country stands at the moment in terms of the progress towards the EPI goal. Intro pages summarize the country commitment and strategic priorities of the CIP, Costed Implementation Plan, to draw the outline of the country's top-level strategic direction for the next few years. Then it outlays the selected priorities for the next 18 months, which follows by the list of actions per each priority, including timeline and responsible bodies. So all the actions of the focal point team, the secretariat, and partners are aligned under each overarching priority to make sure all the actions and efforts are collectively taken to achieve those. These plans are made available on the EPI 2020 country web pages. In April 2017, HIPS advisor onboarded as a part of EPI 2020 team to provide a bridging role between the HIPS and EPI 2020 and to support the promotion and dissemination of the HIPS in close work with USAID and WHO's IBP team. So under this role of the HIPS advisor and engaging with other experts, we do analyze HIPS in country commitments, CIPs, and country action plans. As a regional focal point workshop are the main venue of reviewing, developing country action plans. We take those opportunities to integrate HIPS into action plans and in country discussions further. In the execution phase of the country action plan, we promote and dissemination of the HIPS on needs and opportunity identified in the country action plan. Through this, we encourage and support the implementation of the HIPS in execution of the country action plans. So I was asked to share about some gaps and challenges that we've been experiencing. So small size team might not be just only problem for only EPI 2020. It's a rather common thing for many of secretariats of global initiative. But I still feel it as a challenge in our day-to-day work, especially to further engage with technical discussion in countries, engaging with implementing partners, and participating in relevant meetings across the globe and regions. And as shared in the previous slide, EPI 2020 has initiated to integrate HIPs in the development process of the country action plan, and knowledge sharing at the regional focal point workshop. But still, there is a large room for incorporating HIPs in high-level policy making and program prioritization process in countries. And this is also related to a room for further alignment between the development or review of national family planning strategies, or CIPs, and global financing facilities investment cases, especially around the resource gap analysis and prioritizing funding. And EPI 2020 mainly works through each country's focal point team, which is through the government, civil society, and core donor partners, while IBP has direct engagement with implementing partners. So from EPI 2020's view, there are 4 areas where opportunity lie. First, this type of regional partnership meeting indeed provides opportunities to learn more about each other's working system and to share knowledge. So today, some of the focal points from India, Bangladesh, Indonesia, Nepal, like joining with us. So I'm sure it will inform the further discussion, like how to align the HIPs into the EPI 2020 and work through the upcoming focal point workshop as well. And second is the added value of newly integrated civil society focal points in the EPI 2020 country focal point structure, who can actually do a bridging role with implementing partners in country for advocacy and promoting evidence-based practices. And share the priorities among global and regional level partners on promoting evidence-based practices is a definite opportunity. And lastly, in most of the countries, there are in-country coordination mechanism or EPI 2020 country engagement working group as a main venue of regular family planning discussions. And most of these working groups involve implementing partners. So that working mechanism must be an opportunity for in-depth discussions for further aligning evidence-based practices with country priorities and action plan. Thank you.
Thank you, Chong-hee Huang, for your very informative and interesting presentation. I would finally like to invite Nandita for a presentation on IBP. There's no need to introduce Nandita, you already know her. She is the one who is leading the IBP initiative at WHO headquarters in Geneva. The floor is yours.
Thank you. Thank you. Thank you for that, and thank you to my other panelists. Very informative and interesting presentations. It's always a challenge being that presenter right before the break. So I hope you bear with me as we go through the IBP initiative, new strategy, and our vision for the future. I want to just start by saying, as Dr. Sharma mentioned, I'm leading the secretariat with a team at IBP, but I'm actually relatively new in this position. I just joined in April. So though I'm new to IBP, IBP is not new to me. I've been very involved in the past. And IBP is not new to India and the region. And we heard from Dr. Bulbul this morning about all the work that was done here back in the early 2000s. In preparation for this meeting, I actually did a little research and I contacted the founder of IBP, Dr. Maggie Usher Patel, and I think many of you know her, lots of waves. I invited her to join us for this meeting, and she was thrilled to hear that we were having this workshop in the region. Unfortunately, she wasn't able to make it. But she did have some really interesting insights into the creation of IBP and why it started and what her vision was. And one of the things that she said really stuck with me. She said, you know, IBP was designed to break the mold of official meetings. IBP was designed to break the mold. And that really struck me, because from the conception, IBP was intended to be different, to be innovative, to shake the norm and break the mold, as she said. And that it's in that spirit that I would like all of us to work towards moving IBP in the future, really thinking about innovating, being different, and breaking the mold, as Maggie said. IBP has a very unique relationship with WHO. Our secretariat is housed there, and that was done intentionally to provide a neutral platform. We have a new Director General at WHO, many of you know, and it's great because he's really been championing and advocating for family planning and reproductive health. One of the other things that he has prioritized, and Rita touched on this a little bit, is more effort to be working at the regional and country level. And I bring this up only because IBP's mandate, working at country level with regional and local partners, really fits nicely with the larger mandate of WHO under Dr. Tedros's vision. As you all know, the IBP mission is to support implementation, scale-up of effective practices and global guidelines, and really capitalizing on our convening power and this ability, using this neutral platform, to share with each other, learn about what works, what doesn't work, and really collaborate with each other to reduce duplication. You can read more about it in our annual report that we put together, so please take a look. As Bulbul mentioned, it was founded originally by WHO, USAID, UNFPA, and 9 implementing partners. One of those, IPPF, is now our current chair, and we're very happy about that, to have Sarah, Dr. Varun, and many others here from IPPF. So Bulbul touched on this a little bit in her welcome, the fact that IBP is not new to India. And I too did a little bit of digging and talking with Maggie. And as I was reading about what many of you who were involved, what you did, what made those meetings different, I noticed a few things that I want to share. You all, at that time, 2003, engaged multiple stakeholders, governments, multilaterals, donors, and partner organizations. You organized country, actually at that time, state-level teams to identify priority practices and develop action plans. It should be sounding familiar. You created platforms for knowledge exchange and learning. And that model was then replicated in many other countries. And what I've realized is that it was created back then, it was replicated in many countries, and we're seeing it being replicated right now. We just heard from the panelists on country teams. We heard about identifying priority practices. We heard about action plans. We heard all of these terms that you, as IBP, back in 2003, were already doing. And so when I think back to what Maggie had said, back then, IBP was designed to break the mold of official meetings. It's true. Back then, this was very different. What's interesting, though, now, is this is no longer breaking the mold. This is the mold, right? So we need to, as IBP, if we're really going to stay true to our mandate to break the mold, we need to be thinking differently. And we need to be working with these existing initiatives that are working on these country teams' action plans to really stay true to our mandate of being different and innovative. Oops. So what's changed? How have we evolved over time? And Bulbul mentioned originally there were 9 founding member organizations. We've now expanded to over 50. And what's really exciting about this is that you can see it's quite a range of organizations. So yes, there are the global international NGOs, but we also have a lot of local, regional, and country-level organizations. Some of who are here with us today, and we'll be introducing them tomorrow. But we have organizations like Wings Guatemala, a very small NGO working in the highlands of Guatemala. We have other networks that are now in existence, like the Reproductive Health Supplies Coalition. And we have regional bodies, like the West Africa Health Organization. So it's really quite a range. And as we move forward, we're hoping to expand that network and really diversify our membership. But the other thing that's changed is the landscape that we're working in. And as you heard earlier, IBP was created with support from WHO, UNFPA, USAID, and those were really the main players at the time when it was created. Now we have many more donors, many more initiatives, many more priorities, all in the family planning, reproductive health landscape. And with all of these, it can be a little bit difficult to sort of find your way, right? And that's what we were struggling with when we were launching our new strategy is, okay, we're in a different landscape, we have a lot of partners, a lot of important work. How do we stay relevant? How do we stay focused and clear on what we want to achieve? And that's what our new strategy is about. Again, you can read more in detail here. But we really centered around 3 very clear objectives. The first one, increasing access to guidelines and resources, and focus really on the WHO guidelines for family planning and reproductive health, the high impact practices, and various tools for scale up. Yes, there are lots of other practices, tools, and we can disseminate using the gateway and other resources, but our core mandate is really on these. Our second objective is to support implementation and systematic scale up. So really working with our partners to help support your scale up and implementation efforts. And one of the things that we're really trying to strengthen, and Ados mentioned this as well, is making the link between really important evidence-based guidelines coming out of WHO and these programmatic interventions. Because what we found is when we talk to our partners, while WHO guidelines are extremely critical and important, our partners don't program around guidelines. They program around interventions. So how do I design my community health worker program in a way that's incorporating all of the evidence-based resources and WHO guidelines needed for a quality program? So really making that link between programmatic interventions and WHO guidelines. And the third objective is on partnership. That's what IBP is all about. So how do we continue to facilitate good partnership with new partners, new donors, really engage each other so that we can collaborate and reduce duplication? We've identified some mechanisms to support our strategy, including more regional and country focus. Under Maggie, there seemed to have been a lot of country and regional efforts. And then for a while, it sort of stayed global. And I think what we're trying to do moving forward is find somewhere in the middle. So we want the global conversations, we want to be part of the global conversation, but we want to take that conversation to the field. And we want country or local, regional partners to feed back up to the global discussions. We're trying to strengthen our monitoring, evaluation, and documentation. This has always been a challenge in any partnership, and we're making efforts to strengthen those efforts. And then finally, institutionalizing IBP and using the knowledge gateway. And what does that mean? Well, all of us in here are IBP champions. But can you tell me for sure that in your organization, every single person knows about IBP? Do they know they have this resource? That's what we want to change. We want everyone in our organizations to own it and understand that this is a resource and a tool for them and for us. I just want to highlight, why IBP? What's the added value of IBP? Because we heard we have lots of other initiatives now. What makes IBP unique and special? And I think it was clear as we were developing our strategy and talking with partners, a few things. One, having a neutral platform is extremely important, and being housed at WHO really offers that. A lot of IBP partners have come up with the term collaboration. Who's heard that term, collaboration? Because a lot of our partners are competitors in many ways, but then we're also asking them to collaborate. And so there's a fine balance between being collaborative and being competitive. The other advantage IBP has is this broker for knowledge exchange, implementation, and scale up. Again, making the linkages, making the networking available among key partners is really an added value of IBP. We have a wide network of NGO, civil society, and academics and on-the-ground partners. And this is not only in terms of our membership, but also the reach of the Knowledge Gateway. How many of you are on the Knowledge Gateway or know that you are on the Knowledge Gateway? I bet a lot of you are on it and don't even realize it. This is one of IBP's tools that we use to communicate, and it's an online network that has now expanded to over 10,000 members professionals working in family planning and reproductive health. And it's quite a wide network. What's interesting is this network, because of the diversity, we are able to make some really interesting connections. So I'll give you an example. Last year, we welcomed Wings Guatemala, I mentioned them earlier, a small NGO, into the IBP consortium. And I sent out the email welcoming them. And then a few days later, I got an email from someone working in the Ministry of Health in Zimbabwe. And they said, thank you for all the emails and thank you for introducing us. We read Wings Guatemala's profile. We are struggling with similar issues. Please connect us. We need to get in touch. And I thought to myself, when on earth would a group in Guatemala working in highlands ever be connected to a Ministry of Health in Zimbabwe? When does that doesn't happen. That happened because of IBP's wide network and reach. And that's quite unique. The other really important point I want to make is IBP, and I'm going to go ahead and use the word, it's sustainable. What other network has lasted this long? You know, we've been in existence, I think, since 1999. They were kind of formalized. And what's really interesting here is that a lot of the communities of practice that are housed on the IBP Knowledge Gateway have really stood the test of time. We've all worked on USAID or DFID or other funded projects, and they come and go. Websites go up, then they come down, discussions are lost. Communities of practice are often created. Project ends, done. But the communities of practice on the Gateway, just because it's been around for so long, have been maintained. And we actually have, you can actually go look at archived discussions on a number of different communities. There's one on emergency contraception. They're very active, a very active group. They've been active since 2004. And so all of this rich discussion, the new evidence being generated, the learning has been maintained and sustained thanks to IBP. So I think that's a really important value add that we can be proud of. Ados mentioned the baseline survey that we did at the start of our strategy, and I just wanted to share a few other results just to highlight kind of how our members use IBP. And it shouldn't be that surprising that, you know, a lot of us are involved in the Gateway, communities of practice, et cetera. And you can see 90% of our member organizations really do find value add to this network, which was great to hear, and we want to make sure that we are serving our member organizations and that number continues to stay high. The other thing that we did in that survey is look at how our member organizations are using the resources that we're promoting. I've just highlighted the top used resources, and you can see the WHO MEC, it was actually the MEC wheel, was very widely used, as were the HIPs, and as were tools for scale-up, which is great. But it also means that we have some work to do, because some of the other valuable tools and resources that we're promoting weren't getting as widely used. So we do have work to do. Yep, okay, sorry. This is my last slide. You know, the title of the session is Connecting the Dots, and I'm getting there, I'm connecting. But I actually want to connect in a different way, because when I think about our global goals, the 120 by 2020, SDGs, it occurs to me that we need to be investing in these three areas: evidence-based guidelines, implementation, policy advocacy, and finance. And what I thought, I tried to visualize this in a different way. It's not connecting the dots so much as a Venn diagram. But I really do feel we all have a role to play in achieving these global goals. When we think about evidence-based, we really look to WHO as the gold standard, or the high-impact practices as programmatic interventions. When we think about policy and advocacy, finance, initiatives like Global Financing Facility, FP 2020 has done an amazing job galvanizing commitment for family planning. And when we think about implementation, we think we have our partners, whether it's NGOs, local civil society, and that's really where IBP has a unique and special role to play. So as we think about IBP moving forward, I just want to reiterate what Maggie had said, really remembering why IBP was created. It was created to break the mold, and I hope as we move forward, we can get feedback from all of you about how we can continue to break the mold on disseminating guidelines and resources, how we break the mold on implementation and scale up, and how we break the mold about what it means to be a valuable family planning partnership. Thank you.
Thank you very much, Nandita. I'll just request the patronage of your attention for 2 more minutes because these people have really woken me up. They mentioned Maggie, and she was a very good friend. My association with IBP goes back to 2003 when I was based in Jordan in the regional office for UNFPA. We organized 2 meetings together. One was in Egypt and the other one was in Jordan, and it was a great experience. We could really mobilize. In the Arab world, family planning is not easy, but we could really mobilize partners, civil societies, and it really did work wonders. So yes, it has been a great initiative. And when I started this session, we talked about the dots and the dots being far away. What we need to do to be successful in family planning, as I mentioned the story of family planning, is not only the dots to come together, but also the dots to be joined together, working together. Working together alone is not sufficient. A step ahead further is sharing experiences together. And when we talk about experience sharing, there are basically 4 stages or steps that we need to think upon, dwell upon. One is sharing the lessons learned. The lessons learned could either be a successful practice or could be a practice where you failed, so that others should not be walking that same path. We don't need to reinvent the wheel every time. If you have been successful, I can copy your example. So the first one is sharing lessons learned. The second step is identifying what I call PPPs, potentially promising practices. These are potential. They have a potential to be successful. They might not be. Maybe they are successful in a small project area. They might not be successful in a large, from a project to a program. But at least we have to identify and share the PPPs. The third step is identifying and sharing the good practices. And finally, coming together and implementing the best practices. This is what IBP is all about, and this is what joining the dots means. We work together, we share together, and we move together to a better and successful family planning program in this world. Now we all join together for tea and coffee. Thank you.
The other advantage IBP has is this broker for knowledge exchange, implementation, and scale-up. Again, making the linkages, making the networking available among key partners is really an added value of IBP. We have a wide network of NGO, civil society, and academics and on-the-ground partners. And this is not only in terms of our membership, but also the reach of the Knowledge Gateway. How many of you are on the Knowledge Gateway? Or know that you are on the Knowledge Gateway? I bet a lot of you are on it and don't even realize it. This is one of IBP's tools that we use to communicate, and it's an online network that has now expanded to over 10,000 members, professionals working in family planning and reproductive health. And it's quite a wide network. What's interesting is this network, because of the diversity, we are able to make some really interesting connections. So I'll give you an example. Last year, we welcomed Wings Guatemala, I mentioned them earlier, a small NGO, into the IBP consortium. And I sent out the email welcoming them. And then a few days later, I got an email from someone working in the Ministry of Health in Zimbabwe. And they said, thank you for all the emails and thank you for introducing us. We read Wings Guatemala's profile. We are struggling with similar issues. Please connect us. We need to get in touch. And I thought to myself, when on earth would a group in Guatemala working in highlands ever be connected to a Ministry of Health in Zimbabwe? When does that doesn't happen. That happened because of IBP's wide network and reach. And that's quite unique. The other really important point I want to make is IBP, and I'm going to go ahead and use the word, it's sustainable. What other network has lasted this long? You know, we've been in existence, I think, since 1999. They were kind of formalized. And what's really interesting here is that a lot of the communities of practice that are housed on the IBP Knowledge Gateway have really stood the test of time. We've all worked on USAID or DFID or other funded projects, and they come and go. Websites go up, then they come down, discussions are lost. Communities of practice are often created. Project ends, done. But the communities of practice on the Gateway, just because it's been around for so long, have been maintained. And we actually have, you can actually go look at archived discussions on a number of different communities. There's one on emergency contraception. They're very active, a very active group. They've been active since 2004. And so all of this rich discussion, the new evidence being generated, the learning has been maintained and sustained thanks to IBP. So I think that's a really important value add that we can be proud of. Ados mentioned the baseline survey that we did at the start of our strategy, and I just wanted to share a few other results just to highlight kind of how our members use IBP. And it shouldn't be that surprising that a lot of us are involved in the Gateway, communities of practice, et cetera. And you can see 90% of our member organizations really do find value add to this network, which was great to hear, and we want to make sure that we are serving our member organizations and that number continues to stay high. The other thing that we did in that survey is look at how our member organizations are using the resources that we're promoting. I've just highlighted the top used resources, and you can see the WHO MEC, it was actually the MEC wheel, was very widely used, as were the HIPs, and as were tools for scale-up, which is great. But it also means that we have some work to do, because some of the other valuable tools and resources that we're promoting weren't getting as widely used. So we do have work to do. Yep, okay, sorry. This is my last slide. The title of the session is Connecting the Dots, and I'm getting there, I'm connecting. But I actually want to connect in a different way, because when I think about our global goals, the 120 by 2020 SDGs, it occurs to me that we need to be investing in these three areas: evidence-based guidelines, implementation, policy advocacy, and finance. And what I thought, I tried to visualize this in a different way. It's not connecting the dots so much as a Venn diagram. But I really do feel we all have a role to play in achieving these global goals. When we think about evidence-based, we really look to WHO as the gold standard, or the high-impact practices as programmatic interventions. When we think about policy and advocacy, finance, initiatives like Global Financing Facility, FP 2020 has done an amazing job galvanizing commitment for family planning. And when we think about implementation, we think we have our partners, whether it's NGOs, local civil society, and that's really where IBP has a unique and special role to play. So as we think about IBP moving forward, I just want to reiterate what Maggie had said, really remembering why IBP was created. It was created to break the mold, and I hope as we move forward, we can get feedback from all of you about how we can continue to break the mold on disseminating guidelines and resources, how we break the mold on implementation and scale up, and how we break the mold about what it means to be a valuable family planning partnership. Thank you.
Thank you very much, Nandita. I'll just request the patronage of your attention for 2 more minutes, because these people have really woken me up. They mentioned Maggie, and she was a very good friend. My association with IBP goes back to 2003, when I was based in Jordan in the regional office for UNFPA. We organized 2 meetings together. One was in Egypt and the other one was in Jordan, and it was a great experience. We could really mobilize. In the Arab world, family planning is not easy, but we could really mobilize partners, civil societies, and it really did work wonders. So yes, it has been a great initiative. And when I started this session, we talked about the dots, and the dots being far away. What we need to do to be successful in family planning, as I mentioned the story of family planning, is not only the dots to come together, but also the dots to be joined together, working together. Working together alone is not sufficient. A step ahead further is sharing experiences together. And when we talk about experience sharing, there are basically 4 stages or steps that we need to think upon, dwell upon. One is sharing the lessons learned. The lessons learned could either be a successful practice, or could be a practice where you failed, so that others should not be walking that same path. We don't need to reinvent the wheel every time. If you have been successful, I can copy your example. So the first one is sharing lessons learned. The second step is identifying what I call PPPs, potentially promising practices. These are potential. They have a potential to be successful. They might not be. Maybe they are successful in a small project area. They might not be successful in a large, from a project to a program. But at least we have to identify and share the PPPs. The third step is identifying and sharing the good practices. And finally, coming together and implementing the best practices. This is what IBP is all about, and this is what joining the dots means. We work together, we share together, and we move together to a better and successful family planning program in this world. Now we all join together for tea and coffee. Thank you.
Much. I'd like us to come back shortly. We are a little behind schedule, so we'll take a 20-minute tea break instead of the half an hour. So let's get back here at 10 to the hour. Thank you.
Good morning, everyone, and welcome to this session on donor perspectives to address country priorities. I would like to invite the panelists, Dr. Amit Shah from USAID, Dr. Vineet Sharma, Shailja Mehta, and Anand Sinha on the dais, please. I have the pleasure to introduce the distinguished speakers, panelists from the donor fraternity. So in order in which they are sitting, Anand Sinha from the Packard Foundation, India. Then we have Dr. Amit Shah from USAID, India. Dr. Vineet Sharma from UNFP Regional Office, Bangkok. And Shailja Mehta from Dashra, India. Before we start, I just want to inform you about the structure of the session. This session has two parts. In first part, we'll have the opportunity to hear from the panelists about their organizational priorities, successes, challenges. And in the second part, we'll have a candid conversation about donor commitment to SRHR and how these investment meets the needs of poor and underserved people in the changing aid architecture. So before I invite, let me share a brief bio of first speaker, Anand Sinha from Packard Foundation, India. So Anand Sinha is the country advisor for Packard Foundation in India with over 22 years of experience in public health. He has been at the forefront of innovations engaging the private sector in the delivery of health services in low-income households and has also led some of the India's most successful market-building initiatives for contraceptives and child health products. So it is my pleasure to invite Anand to talk about the organizational work in India.
Okay. We're supposed to be breaking the mold. So in that light, I'm not going to talk a lot about what the Packard Foundation does, but just give you a really high-level view of why we're here. The Packard Foundation has been in India for the last 22 years, working on three key issues around population reproductive health. One is access to family planning, and the focal area in that is really looking at providing family planning through a quality lens, The next one is really working on adolescents, working with adolescents and youth, both from a perspective of providing services that are catering to the needs of young people, but also looking at engaging young people as leaders and as people who actually shape those programs. And the third key area is really in abortion. In India, there are fewer and fewer donors who are working in that space, but we're one of the handful who sort of remain committed to that. This has been our focus for the last 22 years, so really when we go through strategy recycles every 6-7 years, nothing much changes. Geographically, we continue to have a focus in Bihar and a little bit of work in UP and Jharkhand we continue to support, but that's traditionally been where we have been focusing. We're really happy to be here as part of IBP and to support this conference. I think the key sort of reason that when we were talking to Nandita about this conference was really looking at it from a regional perspective and how do you bring local partners, CSO, local CSO organizations and young people to this platform, because I think there is an important learning opportunity that exists through platforms like this. We will continue the conversation, but that's a little bit about the Packard Foundation.
Moving to the next speaker, Dr. Amit Shah from USAID India. Let me go through a brief bio. Dr. Amit Shah is currently working as the Division Chief for Family Health at USAID India office. He oversees USAID-supported health projects aimed at improving maternal and child health, family planning, nutrition, and WASH outcomes spread across several high-focus states in India. Please join me in welcoming Dr. Amit Shah.
So I guess Anand didn't deserve the applause. I was the lucky one who got the applause. It's always tough to follow Anand. I was seated first. I hope that he will follow me later. So thank you, Damil. It's a privilege to represent USAID here at this very important meeting. USAID has been programming in India for more than 5 decades. And this collaboration spans multiple program areas. But by far, family planning has been one of the most important areas and seen the largest investments in the health sector. This programming has been in collaboration with the government of India. We are one of the largest bilateral funding agencies, so all the programs are aligned to the national priorities. But we work very closely with the different state governments and also with all the civil society organizations and the professional associations. Now, as you know, and there are a lot of participants from other countries, that India has changed. And we have graduated from a low-income country to a middle-income country. And what that has done is that has impacted our relationships with the various stakeholders as well as our programming strategies also. So just let me elaborate and give you a few examples. So when we talk about relationships with other stakeholders, it's not the traditional donor funding agency relationship that we have. And it's across the different stakeholders. So when we go to the government of India, the entire family planning program is a self-funded, 100% self-funded program. All the HR, drugs, infrastructure, all of that is funded by the government of India. Same at the state level. So all that they are interested in, whenever you reach out to them, it's always, we have the resources, we do not need your funding. It's about TA, it's about technical assistance. So our aim is always, how do you procure that cutting-edge technical assistance, which can help the government and the state to test, refine new approaches, which can then be scaled by their own resources. So that's the relationship which has changed with the government of India as well as the state government. If you look at our relationships with all the other donor partners, such as Anand, others in the room, initially it used to be more at a information sharing, learning of best practices to prevent duplication. But now, increasingly, we are moving towards co-design. With our limited resources, how can we maximize impact in India? It doesn't make sense in operating in silos, so we are launching a lot of co-designed programs. So with the Bill and Melinda Gates Foundation, we have launched an ambitious $12 million challenge initiative for healthy cities, which is looking at improving the contraceptive prevalence amongst the lowest quintiles in among the urban poor population. Similarly, with Packard, MacArthur, as well as the Gates Foundation, we are looking at mining the NFHS4 data to generate a lot of research, secondary research, which can influence then program and policy. Likewise, with Dasra over here, one of our partners, we are launching a very ambitious 10 to 19 adolescent collaborative, which can generate up to $50 million for adolescent programming in the country. So our nature of programming, our nature of relationships with other funding agencies has also changed. Our nature of relationship with our implementing partners has also changed. Increasingly, we are encouraging our implementing partners to tap into other resources also. It cannot be only solely US-aid resources. How can you get a larger pool of resources to program? And there is more rigor on sustainability as well as skill. So that's in terms of relationship. The second point I would like to highlight is in terms of programming. So again, in 2012-2013, the government of India then launched the integrated RMNCHA programming, and it was no longer those vertical silos of only FP programming or only adolescent programming. The government of India, and we are here to support the ministry, when it launched the ambitious program, that itself was a big strategic shift for us. How do we ensure that our FP program is also integrated within the larger RMNCHA strategy? Secondly, we have learned from global experience as well that system strengthening is the way for the future. You have to strengthen the systems. Now, this itself is a change in programming rather than those vertical programming silos. In terms of challenges, both the things that I have mentioned, whether it's partnerships or whether it is those programming, those are fraught with challenges. When you look at partnership, that's a new buzzword. But how do you ensure that in spite of having the shared vision, how do you have those partnerships in a very timely manner? How do you ensure that you have those metrics, right metrics to measure the value and the success of the partnership? Similarly for programming, when you go into an integrated programming mode or a system strengthening mode, how do you ensure that your core family planning outcomes are delivered at the end of the day? So these are some of the challenges, and I hope that together in collaboration with all the stakeholders that we will be able to succeed. Thank you.
Thank you, Dr. Amit. Really touching upon a lot of areas in terms of integration and partnerships and how it overall influence primarily the role of donors in terms of catalyzing change in a large population base. Moving to the next speaker, Dr. Vineet Sharma from UNFPA. Dr. Vineet Sharma is the Regional Technical Advisor for Reproductive Health and Family Planning in UNFPA's Regional Office for Asia and Pacific region in Bangkok. He has also played a pivotal role in key programs during his years with UNICEF and WHO in India. Dr. Sharma has won a number of international awards, and including International Association for Adolescent Health Award for Innovative Research. Over to Dr. Sharma.
Thank you, Jamil. A planned family is a family that is developed and is a family that contributes to national development and sustainability. A family where mothers and daughters are respected is a family that contributes to community and national development and international development. This is what we believe in strongly. UNFPA is the lead UN agency for family planning and maternal health, or what we call sexual and reproductive health. Globally, our agenda has become revolutionary now. We have set ourselves 3 transformative goals. The first one being zero preventable maternal mortality by 2030, zero unmet need for family planning, and zero gender-based violence. These 3 transformative goals define our work. Globally, we have been working on sexual and reproductive health and rights. All our programs are based on 2 principles. One is the principle of human rights-based health care, or human rights-based sexual and reproductive health care, which is one, and which includes improving the quality of care. And secondly, empowering women. This is women and girls. This is what we believe in strongly. Our programs include sexual reproductive health, maternal health, family planning, adolescent health, preventing maternal deaths and mortality and morbidity, gender equity, equality, and empowerment, preventing gender-based violence, as well as population and development. We provide support to censuses all over the world. In India, our program has been a very old program, and we have provided technical support to the government. We are again the lead UN agency for procurement and supplies of RH commodities, essential RH commodities. We have been strengthening supply chain management, including the LMIS that has been mentioned, including the innovation of the SMS-based or mobile-based supply chain management in many states of the country, which is now being upscaled. We provide evidence-based advocacy to the government to make sure that the SRHR agenda continues to be in focus and is promoted. We provide technical support to the governments, as well as we are strong partners in capacity development. So we have been working comprehensively to make sure that the agenda of sexual and reproductive health and rights is enshrined in national policies and programs, and that the health of women, girls, boys, everyone is promoted under the universal health coverage. This is just an introduction. We'll come back to the details later. Thank you.
Thank you, Dr. Sharma, for highlighting the 3 transformative goals and issues related to quality of care, and particularly contraceptive supplies, which has become a very critical area for family planning programs. Moving to the next speaker, Shailja Mehta from Dasra. Let me just quickly go through the biodata. Shailja Mehta leads 10 to 19, Dasra Adolescents Collaborative, a high-impact platform that unites funders, technical experts, government, and social organizations to reach the 5 million adolescents and move the needle on outcomes key to adolescent empowerment. She was a founding member of a child protection-focused non-governmental organization, Angam. May I request you to share your organizational work?
Sure, thank you. Thank you very much. Thank you, IBP, for having me here, and to all the panelists, thanks for bearing with me. I realized that Dasra is a little new to this room. We're not usually in meetings such as these, so we're very honored to be part of this inner circle. And just to say at the outset that partnership, sharing best practices is something integral to us as an organization, so very happy to be here. I thought I'd give a quick organizational overview and then go a little bit into the Adolescents Collaborative as the initiative that's most relevant here. Dasra is a unique organization. We call ourselves an intermediary. We're a non-profit, and our focus areas are really 2. One is to look at ensuring that philanthropy in India from all channels, including globally, is sustainable and is smart and strategic. And by that, we want to ensure that the philanthropy that goes to the development sector is something that is well thought out. It is helpful and valuable to the nonprofit and the development community, and that it's sustainable and helps the organizations in India build themselves up to be high-impact organizations, to scale, and to ensure that we build institutions in India which are nonprofits. So a huge part of our work is working with philanthropists like corporates, HNIs, family offices, as well as foundations and agencies like USAID, Packard Foundation, etc., to ensure that we work with them on their philanthropic objectives, as well as keeping the Government of India priorities in mind across a few ministries. So that's one part of our work which liaises with the philanthropic community. And the second part of our work is more sector focused, in which we work across 3 sectors. One is adolescence, The second is urban wash, and the third is governance and democracy, so system strengthening and participation in democratic issues. So that is the kind of work we do. And Dasra in Sanskrit actually means enlightened giving, and so all of our effort revolves around that. Just to zoom in a little bit quickly into what we do around the Adolescence Collaborative is we have 4 outcomes across which we work: delaying age of first pregnancy/birth, delaying age of marriage, completing secondary education, and increasing the agency of an adolescent, efficacy, esteem, decision-making, mobility, all of that. And we've looked at using a holistic approach towards working across adolescents. So we work with 5 stakeholders. We work with the government, we work with the philanthropic community, funders, funding agencies, we work with implementation partners. We have a cohort of about upwards of 200 NGOs that Dasra works with across the different sectors, and more than 60 that work on adolescent and RM and CH+A issues. So we work with implementation partners, government, funding agencies, as well as experts and academicians, keeping the adolescent at the center of our work. And ultimately, our goal is to ensure that we all work in a holistic way on intersectoral programming or comprehensive programming to ensure that these 4 outcomes are achieved through both very specific, direct implementation on the ground in a state-specific approach, as well as creating a community of practice that looks at learning, sharing of best practices and high-impact practices. So that's a quick overview. I can go on, but...
Thank you, Shalja, for giving a kind of a comprehensive view of your adolescent program and the value of philanthropy and how that can be promoted across. We have come to a brief overview of the organizational kind of work that is taken up by the 4 leading donor agencies. We move to the second part of this particular session, which is having some in-depth ideas about specific issues. And to that, I'll first move to Anand. And this is regarding, as we have seen that given the Packard's Foundation's commitment to innovation and trying new approaches, how do you balance the need to innovate and be creative with the need for measurable results? And why have you chosen to focus so much of your investment in young people?
So the question is, how do we balance innovation and measuring impact? Well, okay, I don't know if you, I mean, I think you can do both of those, but I think we tend to think of it as innovation and scale are 2 things that don't necessarily go hand in hand. If there are organizations who are trying to incite innovation, explore new areas, then typically working at scale at the same time, at the same pace is usually not something that goes hand in hand. It's a different type of a DNA of an organization. And I think those 2 typically don't rest easily in the same portfolio. And especially in India, when your investment portfolio is less than 1% of the annual health budget, and as a donor, you really don't have any ability to sort of directly deliver scale. What you have an ability to do is to deliver or try and influence a conversation and thinking around the kind of interventions and solutions that are being thought about in India. I mean, the largest donors in the family planning space aren't at this table. The Gates Foundation, bigger than that is, of course, the government of India. And they influence, I think, the ability to sort of go to scale at significant levels. But, I think we like to work in that space primarily because we have, to a certain extent, I think, liberated ourselves from the onus of delivering impact at scale. We do not feel at the Packard Foundation that we're responsible for delivering impact at scale across India. What we feel we're responsible for is providing the space for people to come together, to come up with new ideas, fail, and come up with innovations that might work. And I think that's also why a platform like implementing best practices is important. how is it that we can actually try and sort of drive some of those innovations and provide the safety and the investment, the low sort of, stress funding that is needed to, and long-term investment that is needed to maybe engender some of these innovations. I think the other area that we do try and work with is slightly more tilted towards civil society and not necessarily entirely beholden to government, which we feel is sort of a traditional approach to donors. Primarily, again, saying how do you try and give more air and voice to civil society organizations as being the natural partners and the natural owners of a lot of these development objectives, versus a worldview that believes that the government is a natural owner and deliverer of these types of objectives. And if you're trying to engender that sort of capability and ownership by civil society, again, it requires you to be able to be comfortable with working at small scale, not necessarily assuming that you're going to have national level impact by partnering with civil society organizations. And I think the other thing, and I've said this to IDOS before, and I'm very supportive of the whole idea of high impact practices, but one of the things that I think we, the Packard Foundation, are sort of also trying to put a lens on is low impact practices. What are the lips, right? We've got the hips, but what is it that we know about what doesn't work? And oftentimes we don't give ourselves a space to figure out what doesn't work, and we keep on chasing and running on those same wheels, hoping that they will eventually turn into practices that will work without recognizing that, giving ourselves a space to say, well, look, this doesn't work, let's move on to something else, and it's okay. And I think that's an important space that we, as a donor community, often give lip service to, but don't meaningfully provide space for. We are trying to hold ourselves, partners, grantees, often accountable for meeting certain outcomes and for delivering in a certain direction without giving ourselves the space to say we actually need to take a step backwards or things haven't worked out as intended. And when they don't work out as intended, let's also say what hasn't worked. I think, I've been sort of personally advocating for trying to build a library of what doesn't work in this space, because we've tried hundreds and hundreds and hundreds of things over many, many years, right? And we found 18 or 19 high impact practices, which are being documented. What about the 200 that haven't worked? Have we got evidence that that doesn't work, or is it just that we didn't do it correctly? I think those sorts of answers become important as you think about how our sort of small funding that is available in the innovation space is actually going to be used strategically. There are much bigger funding available in sort of when we get to impact or delivering large-scale service delivery programs. But, again, we hope that those are based on significant evidence. But again, a lot of our policy making is not evidence-based. And we recognize that there is a need to sort of have a civil society that is able to hold that conversation and is not scared to use the A word or the accountability word, which I think we often do step away from in coercive environments.
Okay. Connected with this particular point, as you have said, that the highest, the greatest gain in health coverage is through the government. That is what came out very clearly. And we also know that the estimated cost of achieving SDGs runs into trillions. And when we look at the donor funding, it is low billion in a way. So how do you, what are the ways of working with other partners to ensure that your priorities are supported to take forward the country agendas?
Well, apart from saying that we try to work in partnership, you try and influence, you try and sort of work in partnership with other donors, you try and influence government proactively, you try and put in place mechanisms where civil society has a voice and has a view to being able to use that voice. I think that for us